I want to thank the organizers for inviting me. You're going to see plenty of me because I'm giving 4 talks in the next 2 days. And I'm going to start off these 4 talks talking about small HER2-positive tumors, a subject that, at least in the U.S., has been... So, by way of background, these are the trials that led to the standard use of trastuzumab in patients with HER2-positive breast cancer. You are familiar with many of these trials. They were predominantly conducted in patients with node-positive breast cancer, and even among those patients who had node-negative breast cancer, the tumors tended to be on the larger side, and I'll get to that more specifically in just a few minutes. As you know, they showed a clear benefit for the addition of trastuzumab to chemotherapy. The chemotherapy was generally anthracycline and taxane-based chemotherapy, as was given in both the NSABP trial and the intergroup trial, where patients received AC followed by paclitaxel or AC followed by paclitaxel with trastuzumab. And again, with the addition of trastuzumab, there was a dramatic improvement in both disease-free and in overall survival, seen in both estrogen receptor negative and estrogen receptor positive disease, and now taken out to the 10 years of follow-up. Now, I mentioned that most of these patients, in fact, had node-positive breast cancer. In the joint analysis, which was the analysis of the NSABP trial and the intergroup trial, only 6% of patients had node-negative breast cancer. In HERA, 32% of patients had node-negative breast cancer, but only a very small number had stage 1 disease, and there only if the tumors were greater than a centimeter. The BCIRG trial was a little bit more flexible. They allowed in any size tumor, but there were very few patients who had tumors less than a centimeter, certainly very few with tumors less than a centimeter with negative lymph nodes. And I think it's fair to conclude that the vast majority of patients in the pivotal trials had node-positive disease, or if they had stage 1 disease, it was typically stage 1 disease with higher risk features, meaning typically that it was a close to 2-centimeter tumor. So in 2005, when we first had these results, there were a number of assumptions and unresolved questions. We assumed that trastuzumab-based regimens would be effective in women regardless of tumor size, and that the principles that we had learned from hormonal therapy and chemotherapy, that the relative risk reduction translates across a broad spectrum of patients, would hold true here. We also recognize that many, perhaps most women and their doctors would want to use a trastuzumab-based regimen in the setting of stage 1 disease. But the truth was that the natural history of stage 1 HER2-positive cancers was uncertain. I think you could argue it's still uncertain, but maybe a little less than before. And particularly the natural history of less than 1 centimeter node-negative HER2-positive breast cancers was entirely uncertain at this time. So the question that many asked then and continue to ask is, how low do you go? And by low, I mean tumor size. So over the past several years, there have been a number of data sets that have looked at this question, and I'm going to briefly go through them with you before going through a trial that we actually conducted at our center. So this is the first report that I'm aware of. It came from MD Anderson, and it looked at roughly 100 patients with HER2-positive, less than 1 centimeter node-negative breast cancers, and actually reported the most alarming numbers of all of the subsequent papers. The 5-year relapse-free survival was 77%. The 5-year free of distant recurrence survival was approximately 84%, meaning that 15% of these women had metastatic disease during the course of the first 5 years. And this led many to be quite concerned. Of course, this was from a retrospective look at the patients seen at MD Anderson. And I think if you know MD Anderson somewhat, you will recognize the fact that there aren't that many patients at MD Anderson who don't get treatment. So the question is, who were in fact these patients who didn't get treatment at the center in the US that probably traditionally gave more treatment than any other center? Now, fortunately, we have other data sets as well, although in truth, I give the MD Anderson folks credit for raising awareness that in fact these patients with small tumors might be at particularly high risk of disease recurrence. So this is from the European Institute of Oncology, from Giuseppe Corliano, and looks also at patients with tumors less than a centimeter. And here they included patients who received hormonal therapy as well as patients who received chemotherapy. In fact, about 50% of the patients with hormone receptor negative disease received chemotherapy. And what you can see is that, generally speaking, patients with T1A tumors had a better prognosis than those with T1B tumors, which is what you would expect, and that for patients with T1B, estrogen receptor negative cancers in particular, that probably somewhere in the range of about 10% of these patients, half of whom received chemotherapy, but none of whom received trastuzumab, experienced a recurrence by 5 years. Now, perhaps the most reassuring data set comes from Kaiser Permanente in California, and this was just published in the JCO this past year. They included a total of 234 patients who had T1A and B tumors. They actually divided the T1B tumors up in terms of those that had tumors between 6 millimeters and 9 millimeters, and those who had the very largest T1B tumors, that is 1 centimeter. And you can see that some of these patients received chemotherapy or trastuzumab. The majority, 171, did not receive either chemotherapy or trastuzumab. And the bottom line here is that the prognosis for all but the patients who had tumors that were 1 centimeter exactly was really quite good, whether they received chemotherapy or trastuzumab or not. And what they reported is that patients essentially had 100% freedom from distant recurrences, unless they had a tumor that was a centimeter, in which case the rate was similar to what was seen in the European School of Oncology study. And then finally, perhaps the biggest data set comes from the NCCN, and this was put together by my colleague, Anesh Vas-Louise, and she looked at just over 4,100 patients in the NCCN data set who were diagnosed with breast cancer between 2000 and 2009 and had T1A or B disease in the setting of node negativity. And these are the characteristics of the study population. She actually looked at all different subtypes, but focusing specifically on those who had HER2-positive disease. There were a total of 520 patients with less than 1 centimeter or 1 centimeter or less HER2-positive disease. And of these, approximately 257 received no chemotherapy or trastuzumab. The others, about half of them, received either chemotherapy or trastuzumab, although most received chemotherapy and had not received trastuzumab. This is the distant relapse-free survival for patients who had hormone receptor-positive, HER2-positive disease. And what you can see is that for those who had no chemotherapy as well as those who had chemotherapy, the prognosis was relatively good, not in truth discernibly very different between the two. But among those who had hormone receptor negative, HER2-positive disease, a somewhat worse outcome. Again, a little bit unclear how much that was modified by treatment largely being chemotherapy. Remember, most of these patients were accrued before 2005. We weren't even giving node-positive patients trastuzumab before 2005. And finally, the last of these retrospective data sets that I will go over comes from the Vancouver Cancer Registry. And I put this in here because it not only included the sub-centimeter tumors, but it included patients who had somewhat larger tumors. And when I describe the study that we conducted to you, and you need a basis for comparison, this is perhaps the better basis for comparison. And this looked at all patients with T1 tumors in the setting of node negativity. And what they found was that among patients who had hormone receptor positive and ER negative or hormone receptor negative tumors, that in fact, looking at people through 10 years out, that about 25% of them experienced a recurrence of their disease. So what can we say? Well, the definitions used in these studies varied. ER, I believe, probably modulates risk in the first 5 years. I'm not clear at all that it does beyond 5 years, and in fact, the data from the joint analysis would suggest that in patients with ER-positive disease, unfortunately, recurrence rates catch up. But with all of these caveats, I think it's fair to say that among patients with T1A tumors, the recurrence risk is somewhere between 2 and 10%. Among patients with T1B tumors, at least affected by ER status to some degree, it's probably in the range of 5 to 20%. And for those with T1C tumors, between 10 and 25%. So you've faced those numbers and you're seeing your patient and you've decided that for whatever reason, either because she has a larger tumor or because her own sense of what's valuable to her, you've made the decision to opt for chemotherapy and trastuzumab. And the question is, what is the optimal regimen? Should you give ACTH? Should you give TCH? Should you give trastuzumab alone, a regimen that has some appeal, but for which there's absolutely no track record? Or should you give other chemotherapy and trastuzumab? And I think this is the quandary that we all faced a number of years ago, and it's with this in mind that we designed a study for patients with stage 1 disease. In truth, we allowed patients in who had tumors up to 3 centimeters, but largely stage 1 patients, which was designed in 2007. We knew at the time that a prospective randomized trial would be the best study, but we did not think we could accrue to such a trial. We thought that giving patients or offering patients a trastuzumab null arm would have been impossible given the desire that people had to receive trastuzumab if they were going to have treatment. The standard regimen seemed excessively toxic. We didn't think that we could compare a regimen such as TCH or ACTH with something less toxic with trastuzumab. And even if we did that, we knew that it would take thousands of patients to be able to establish equivalence or see a difference. Trastuzumab alone was a possibility, as I mentioned, but we didn't think it was optimal given the fact that there was no track record. And as I've mentioned, a randomized trial would have required literally thousands of these patients. And for all of these reasons, we elected to conduct a large prospective non-randomized trial. And this is the trial. Patients with node-negative disease up to 3 centimeters were enrolled and received 12 weeks of paclitaxel and trastuzumab, followed by the completion of 1 year of trastuzumab given every 3 weeks. And the statistical considerations are shown here. I won't go into them in great detail, but suffice it to say that we felt at the time that if in this group of patients who had largely stage 1 disease, not just subcentimeter disease by any means, that a 3-year failure rate of 9.2% would be unacceptable, that a 3-year failure rate of less than 5% would be acceptable, and we powered the study to be able to look at that potential difference with a planned sample size of 400 patients. These are the patient characteristics. The age is of no surprise. About half of the patients had subcentimeter tumors, most of whom had T1B tumors. About half had tumors that were T1C or T2. The histologic grade is what you would expect, and about 2/3 had ER-positive tumors. And these are the results that my colleague, Sara Tolaney, presented at San Antonio this past year. The 3-year disease-free survival was 98.7%. The confidence intervals were 97.6 to 99.8, with a p-value based on our initial assumptions of less than 0.0001. And if you specifically look at the disease-free survival events, you actually may feel even a little better. There were 10 such events. 4 of these were local regional recurrences. 3 of them were new contralateral primaries, all 3 of which were HER2 negative and which we could not expect to have prevented with trastuzumab. And 2 were distant recurrences. Finally, there was 1 event which was a non-breast cancer event, but because of the rules and the way the study was set up, we had to count. And if you look at recurrence-free survival, which excludes the contralateral cancers and excludes the unrelated breast cancer death, the 3-year relapse-free interval was 99.2%. Now, all of this was administered with the toxicity that you would expect with paclitaxel and trastuzumab. I have to say that it's remarkable when you give a regimen that you perceive as being relatively low in terms of toxicity, but which for the patient is much more than getting nothing. It still feels like more chemotherapy than most patients would like to receive, but clearly the toxicity was less than you would see when you give either an anthracycline or TCH. And from a cardiac toxicity standpoint, there were 2 patients of the 400 patients who had symptomatic congestive heart failure. Now, there are some caveats and limitations. This is a single-arm, non-randomized trial. Approximately 20% of the patients had T1A tumors with a very favorable prognosis, and I'm not for a minute suggesting you should be treating all of those patients, or even ideally that we should have included them. There's a higher proportion of hormone receptor positive tumors in this study compared to the pivotal trials, although this seems to be consistent with other studies that have looked at the presence of hormone receptor positivity in patients with small node-negative cancers. Consistent with recent node-negative reports, this is consistent with recent node-negative reports, and in fact, the existence of more hormone receptor positive disease may be associated with more later recurrences, and for that reason, we will be continuing to follow these patients. But what are the implications from our standpoint? Well, we think that paclitaxel and trastuzumab can be considered a reasonable and appealing approach for the majority of patients with stage 1 HER2-positive disease, whether the tumor is less than a centimeter or, for that matter, greater than a centimeter. We don't for a minute think that all patients require trastuzumab and chemotherapy, particularly those with the smallest tumors and those with hormone receptor positive disease with relatively small tumors. And standard regimens from the pivotal trials can certainly be considered for patients with particularly high-risk features. In all, biologic regimens such as trastuzumab and pertuzumab might have even lower toxicity and could be tested in this setting. But in our view, if you're going to give paclitaxel and trastuzumab, there is absolutely no justification in this patient population to add another biologic like pertuzumab. So THP would not be an appropriate regimen here. We just do well enough with TH alone. And I'll share with you my own view of this. This is what I call Eric's equation. And I will also share with you the fact that I don't like the TCH regimen. So keep that in mind. But in the BCIRG trial, ACTH actually had a 3% absolute advantage over TCH from the standpoint of disease-free survival. In my view, TCH is equivalent to TH, docetaxel and trastuzumab, which has been shown in the metastatic setting and the neoadjuvant setting. And with that in mind, TH and TH, docetaxel, trastuzumab, docetaxel, Herceptin, and paclitaxel, paclitaxel, Herceptin are probably equivalent. So with all of this logic, if you follow it, I actually think that TH could be a little bit worse than ACTH, and that might be of relevance in a group of patients who had node-positive breast cancer. But in this lower risk group of patients, I can't imagine how the benefits of adding an anthracycline or giving a more complicated regimen could outweigh the risks. We're now conducting another study. This is of a relatively similar design, except there is a randomization, but the randomization is largely to look at toxicity. And in this study, a quarter of the patients receive TH, which we view as the standard, and the other 3/4 receive TDM1, seeing if we can actually reduce the toxicity further. And this is the last slide. How do I view treatment for stage 1 HER2-positive disease? Well, for patients with T1A tumors that are ER positive, shown in the bottom white, I would say generally not, and very selectively among those with ER negative disease. For those who have T1B ER negative disease, we typically give treatment. And for those with T1B ER positive disease, again, we sometimes do, but very much weighing the pros and cons with the patients. And we do for patients who have tumors that are greater than 1 centimeter, which I realize is not the topic I was asked to address. But when we give chemotherapy, we give the TH regimen. And I think that I'm about 24 hours away from being able to say that this paper is in press in a very well-known journal. So when you read it and you see it, it'll make you that much more comfortable. So with that, I'll end, and I think later on there'll be questions, perhaps. Thank you.